Good afternoon, everyone. Good afternoon. I know it's been a long day, but we are excited to talk about representation and how it matters in data, race, equity, and health. My name is Tayler James. I am the Director of Research for The Plug, which is an organization that focuses on the innovation and tech within the Black ecosystem. And I'm going to let everyone else introduce themselves and just give a high-level overview about the kind of work that you're doing in equity, race, and health.
You want to start?
Hey everyone, my name is José Morey. I am a physician by formal training. I'm the Chief Medical Officer and co-founder for Ever Medical Technology. We are one of the largest blockchain-based electronic healthcare records. We're based out of Southeast Asia. We have about 10 million records throughout Asia, South America, and Africa. And we're focused on giving people and individuals power over their medical data to be able to move around freely and to be able to commoditize and commercialize their data at will.
Hello, my name is Margaret Brown, and I am the Senior Director for Community Partnerships at Sharecare. And in my role, primarily building partnerships with communities to use data to understand their well-being profiles of both individual health, SDOH factors, and then to customize implementation of solutions to address those issues.
And I am Kim Desmond. I am the Chief of Race and Equity for the City of San Diego, and I serve for Mayor Todd Gloria, building the first Race and Equity office.
Yes, I'm Gabriela Sabaté, and I am, I've been for a long time in technology in companies like IBM, venture capital companies like SoftBank Venture Capital in the first fund. And since 2011, I've been in digital health and doing a lot of work in prevention, working with underserved populations, prevention programs, and I had Health Semantics, but also, which is a company in digital health, in prevention of chronic disease and management, as well as Cludi and Curalo, and we do population health and EHRs as well.
Awesome. So we have a very diverse panel, and they are experienced within their field. Super excited to get this going. So let's go. Gabriela and Margaret, data-driven technologies have become influential within the healthcare sector due to its ability to detect diseases earlier and more effectively, while identifying resources needed to support specific communities. What is your perspective on how data can and will equitably benefit underserved populations?
Yes, I think that is crucial. I think that data and the correct collection of data lies at the base of really achieving health equity in general, and that has been apparent during the pandemic, where there has been a disproportionate impact not only in the healthcare, severe disease, deaths, outcomes of COVID disease patients in underserved communities, Black, Latino communities, especially, but also in the economic impact and social impact as well. So I think that improving the collection of data on one end, but also improving the standards by which data needs to be collected. For example, at the federal level, there's a minimum standard to collect disaggregated data that has to do with racial data or ethnic data is not necessarily disaggregated, and there are minimum standards, but those haven't been revised since 1997, and today's population doesn't really reflect what was being thought perhaps in 1997. And then to coordinate that data collection and as a means of analysis, as a means to accountability, as a means of improvement, collecting that data is also a little bit disconnected, or it needs a better connection between the federal levels and the state levels and the municipal levels or the city levels. Because I think that we cannot have a smart city unless we have good data that leads into better lives and access to healthcare and outcomes for all populations that live in a city.
I love it.
You know, I've often heard that the drive to health equity or the thought of health equity is both a process and an outcome. It is a journey and it's a destination. And it's messy work. We make huge gains and we have huge setbacks. And those setbacks can be attributed to anything from the pandemic to what happens in the political arena to what natural disaster and things like that. And the only way that we are really going to understand if we're winning or we're achieving this goal towards health equity is that we are going to have to bring together all of the data sources, publicly available data, proprietary data sources, healthcare data, understanding how our populations are similar and how they're different to be able to scale solutions to have the most impact. And I really feel that the issue of data access has to be tackled to make sure that municipalities and state governments, very much like you're saying, all the way down to an organizational level can really understand the populations that they're responsible for. So if we're talking about an employer who's responsible for 100 to 3,000 or more employees, they really need to understand how the differences in their population really do matter when they're bringing their benefits. When you're talking about a community, you have to understand, you know, not only what the demographics are, but how are those individuals experiencing that community differently, and how have public funds been used to impact a community at a disproportionate rate. So, you know, using data in those ways is going to be important as we continue this march towards creating equity in health.
Really great insight. Kim and Jose, both of you guys played a pivotal role in the COVID-19 pandemic. Can you tell us a little bit about the application of data science and what it revealed for societal and structural inequalities, specifically within the healthcare system during the pandemic?
Sure. Kim, please.
I didn't care to relive in the pandemic that we can never get out of.
Yeah, I mean, we currently still are in the pandemic.
I think your question is an important one, and definitely like serving in the operations of the pandemic really played out the things that we're talking about. And to bounce off what you stated in terms of it's a equity as a process and an outcome, I think to your question, it's important to set the stage around how do you define equity. So if you add in it's a process and an outcome, a lot of my work centered on really setting the stage to say, how do you define equity? How do you define equality? These are words that we use all the time. Like the word equity is overused at this point because I think we don't have meaning around what that stands for. So in the pandemic, when you think about process and outcome, I look at equity in terms of the operation side of it. It was saying we're talking about outcomes and data. You're not doing equity work if you are not addressing a disparity. And so we would have our city employees, they would say, we're doing equity work, and I would say, show me your data. And then I would say that equity is symbiotic to equality. You have to go through equality to get to equity. You have to say, what do we all need? And then you say, where's the disparity? And so understanding that equity and equality is symbiotic, and the pandemic response, it allowed us to say, we all could get COVID-19, but the disparities, the racial disparities, had everything to do with systemic, historic racism that we saw in the healthcare systems. And so, and in the context of local government, equity becomes a corrective remedy to systemic injustice and more precisely to institutional racism, because you're really looking at the outcome and then you disaggregate the data part. So in the pandemic, we did a lot of that. We looked at COVID rates by race, ethnicity, gender, age, and then we said the response to deploying the vaccines had to be strategic. Because if equity is the corrective remedy, you gotta know who and how and which neighborhood does not have the systemic infrastructure. So our team, we deployed vaccines, but there are neighborhoods that didn't have a clinic. They didn't have a rec center. And so local government, we built those things. We build neighborhoods. So it became our goal to have to reverse design to say, where is it not at? So I hope that addresses your question, and hand it to my colleague.
Thank you, Kim. More of the same, really. So My background being a physician, after that I studied artificial intelligence. So I was Associate Chief Health Officer for IBM Watson Health, developing AI applications globally in medicine. And I was asked to help on a project called CORD-19 that was started by the White House Office of Science Technology Policy. So what it did was it brought AI nonprofits and for-profits together to be able to create an application to rapidly identify data and see what COVID-19 was doing, how it was affecting things, if we could identify new types of diagnostics and therapeutics rapidly. But what we saw is the data that was coming out, it showed the systemic inequality. And we talk about how the pandemic affected everyone, right? But it didn't affect everyone the same. And it affected Black and brown communities far more than anyone else. And that's true because of the systemic inequalities that have been throughout the entirety of our system. And it shows that our healthcare system has always been sick, and it has always been frail, and it has always disenfranchised the most disadvantaged among us. And that was the thing. So COVID disproportionately affected Latino communities, Black communities more than anyone else. And that was something that was coming out of the data, that we needed to be able to help those people faster and more rapidly. And that's one of the biggest things that we see in a lot of healthcare data. I mean, if you create any system, so artificial intelligence isn't racist, isn't biased in and of itself. But if you allow it to learn from racist and biased data, then it will have a racist and biased outcome. Microsoft saw this rapidly with the Twitter bot that they allowed to learn from tweets, 5, 6, 7 years ago, Cortana, I think it was the name of it. And within 3 hours, I think it became misogynist, anti-Semitic, and racist because it was learning from biased data. And so if you do not have, and you're not cognizant of where that data is coming from, if you utilize data that was based on redlining techniques, then guess what? You're going to have outcomes, and you're going to have an artificial intelligence that perpetuates that same racist tendencies. So we have to be cognizant and understand where the bias is in data as we develop these things. And to the point of my colleagues earlier, we do need multifaceted data sets to be able to create and really get to the nirvana of healthcare, right? To be able to start predicting disease and potentially preventing disease from it ever occurring. But to do that, we do need multi-omic or panomic data sets. But who controls that data? And who watches over them? And that's why I'm a strong proponent that these are the systems we need to create, but I truly believe that blockchain is the foundation for that because it's fully transparent and it gives back empowerment to the individual. So that power is not in the hospital. That power isn't in the Googles. That power isn't in the government. That power is at the individual, and you can transparently see who accesses your data, why they access your data, and we could potentially commercialize our own data, which other companies are already doing. But then that revenue comes back to the individual, or a portion of that. And that's, I think, part of the component we have to do.
I love it. And I'm going to open this question to everyone since we're on the topic of blockchain. Recently, Deloitte issued a report revealing that blockchain technology potential to transform healthcare by increasing the privacy and consistency of healthcare data. The system provides a new model for health information exchanges by making electronic medical records more efficient and ultimately placing patients at the center of their data and the medical ecosystem. What does healthcare look like and data and healthcare look like over the next 5, 10, 20 years?
Yeah. Here, Gabriela. Gabriela, do you want to?
Yeah. Yes, thank you. Well, I think that healthcare is a space where I'm a big believer in blockchain technologies and in Web3 in general. Perhaps in healthcare, it will take a little bit longer because it's a highly regulated space, but at the same time, I think that these, the set of technologies that now we call Web3 comprise or have the characteristics that allow them to be specially suited to as we were all saying, to solve many problems that are pertinent to healthcare. For example, you know, I'm an advisor and investor in a company called Genobank.io. And what we do there at Genobank is I would say a secure, transparent protocol that ensures that your healthcare data, but specifically genomics data and bio-NFTs and also providing for lab-certified NFTs as a medium to really gate that data from whoever you want to share it with, and at the same time empowering the patient or the person in their healthcare journey and unifying, in a sense, their identity, or at least their healthcare identity, into one source. Because whether you want to monetize it or not, at least you want to have control and ownership of the data that's yours. In the meantime, we'll have to wait, I think, for things like regulations with the hospitals or the providers that get to see you. They have to log your information in their own EHR systems and whatever they are, and they're sanctioned, and they have to keep that information for legal purposes for a number of years. So all of those things need to come together. But I think that we can start working not necessarily at the big hospital level implementing blockchain day one, but yes, there are solutions where zero knowledge proofs are going to be fantastic ways of, for example, I totally dislike when I travel these days and I have to take an American Airlines flight and I have to give my COVID-19 vaccine or other information related to COVID-19 to a third company, to a third party. Why? They're logging all of my information in their own servers. That shouldn't be happening, right? So I would expect that sooner than later, these applications, not only the ones pertinent to my direct health, but also the ones that contain healthcare-related or privacy-related information, are going to be under my control, and entities in this case, the one that I mentioned in boarding a plane should be a pass-through entity that they can certify. They can do their part of the value chain without keeping my data in the process, without or at least perhaps you authorize it because you say yes, I abide by the terms, but it's not really that you're authorizing your data being used in any specific way. So.
I would concur. I think we're going to see what we're seeing in a lot of other industries where it's us, the individuals, that actually control our own data and get to decide who uses our data, how they use it, and when they use it. The U.S. model, obviously now, all of us has probably had some sort of interaction with healthcare at some point of our lives through family or ourselves, and it's such a hassle. I mean, because your data, when you give it away, it's just like with social media. You sign your data away, and the hospital gets to own it. And then HIPAA, all that allows you is you're requesting access to your data because you've given it away to the hospital. So the model of the future and what we've created already outside of the US, and that's unfortunately outside the US, it's going to progress much faster than inside the US, where it's the reverse. If hospital wants access to your data, they have to ask you for permission. That's the way it should be. It is your data to begin with, so they have to request data from you for them to use it. And yes, you can set it up on the back end so that it's very easy for, if it's anyone with an MD or a clinician, they can see it for anything. But then you track it and you see. And that way you don't have hospitals making extra money from your data, selling it to the Googles and the Facebooks and the IBMs of the world. And then you can choose to be forgotten if you so choose, or you can actually commoditize your data. And we have 3 pilot projects right now with AstraZeneca, Roche, and Valo Health, where they're actually paying the patients individually for access to their data to be able to make diagnostic and therapeutic evaluations. So that's the future.
Yeah, I have to say something because I think you're spot on in that I want to bounce on you actually, in that process and outcomes is important, and I will also say context. In the pandemic, being in the government, we were responding to the pandemic. And so when that happens, you command all branches of government and sectors. And so we had to command the sector of health, working with the mayor and the governor and the national level to say, how do you deploy resources? And so I think this conversation around how do you use PII data and how do you uphold the integrity and also balance how governments respond. Because as a person who was in that situation, and I was over the whole branch of government for people, that we had to use and look at the data to say, how do you respond in an inclusive approach to address the clear racial disparities, structurally and individually? So I think there's a fine line, and I definitely think we got to think about context, because in the pandemic, it was like people are dying, right? We got to get, I'm not going to argue what you have and I have. We're going to figure out how to get this done. So I think context matters, and collaboration with government is important to make sure you're protecting folks and they have control of that.
I agree, and such a wonderful conversation. I will say, wearing the hat of, individual and community advocacy, when I think about data and individuals owning their own healthcare data, I also think about the amazing opportunity to fast track this road to health equity by, any one of us who have been charged with taking care of a chronically ill family member, parent, senior in your home. You know how challenging it can be to be that person's advocate, right? You can't get access to all the details of the data, or exactly what prescriptions they're taking, or exactly the types of in-home treatments they should maybe be having. And so how can we take this data to turn it on for a tool to use individually and in support of those in your family to say, I can see in the record X, Y, and Z. I can see this. I'm looking at it. And you're going to be able to identify where there's biases. We live in an imperfect world, and we have healthcare providers that don't understand our culture, or maybe don't speak our language, or don't understand the nature of our family systems, et cetera. We are going to be able to look at that data in a transparent way and become our own best advocate and go the avenues that best suit us, best suit our culture, best suit our language, that match us. And I look at that as a wonderful place to be into the future.
I absolutely love that. We've talked about understanding our cultures and making sure that we're represented. A lot of marginalized communities, Black and brown communities, they don't trust due to historical issues, being treated as guinea pigs. And how do we combat that? How do we ensure that their data will be equipped and used to pour resources into those communities, or will it?
I think about the work that we've done at Sharecare within a lot of the community efforts that we have, and we do use data. We collect data, both self-reported perceptions of health. We layer that over with the SDOH factors that come from a wide range of sources, proprietary, public, et cetera, data sources, to paint a profile of communities, to understand really what is happening there. What are people reporting that they're experiencing, together with what we know the systems and environments that have been designed there are producing. So when we talk about SDOH, a lot of those things are systems that were designed to get a certain outcome, and some of those outcomes are exactly the disparities or the inequality that we see. But making the case to communities on how to then take that data and arm themselves to then go to their government leaders, to go to their healthcare leaders, think about school leaders, every sector of community, to become that community's own best advocate, to begin having a voice in redesigning these communities for the way in which those individuals need it to be. From a cultural standpoint, again, you cannot get away from that. From a language standpoint, what is really best suited? If you are a member of a community, even at the neighborhood level, you know what's going to work best for you. If you're lacking transportation, you know the modes of transportation that are going to best meet your needs. What's that ideal state? If you're lacking food resources, whether that's healthy food or just food generally, you live in a food desert, you know what the solution is that would best meet your need. And you really need to be able to take the power of the data that you're sharing transparently with those elected leaders to become the advocate to make that change.
Yes, I completely agree with that. I think that in building the trust, which is what you mentioned, and it's such a key word, trust, and I would also add fear, because some communities don't trust, and when that's combined with fear, it's a horrible situation, right? And if you look at the census itself, it's underreported. And especially in the Latino, I'm a Latina myself, so I've been trying to convince Latino people that I know to answer the census. Mm-hmm. And probably a part of that is tied to education and getting the word out, but that's going to be like a slower uptake on one end. I think that in as much as we can derive from existing data. Also, another data point that's interesting is at the beginning of the pandemic, the data was not disaggregated for racial and ethnicity. But then with the vaccines coming in, even still with the vaccines and still to the date, like 40% of the ethnicity and racial data is missing. So that makes it very difficult to devise plans, to design new plans to, where are the problems? What you cannot see, you cannot address. So where are the problems? Where are the big inequities? We have the resources in several big cities or big communities, but not everywhere, obviously. So the first thing is to see. The second thing is to address and do something. And the third thing is to be able to measure the plans that are in place, how they're doing, what the outcomes and results have been. And the last part is the accountability. So who is accountable for the results? No? So those are the four parts that I see. And I think that a catalyst for this would be get real leadership within the communities, for one, but also there's a figure in healthcare that's the community health worker, that is a person it's not a social worker, it needs a license. It differs from state to state how they get the license, how they get licensed, what they can or cannot do, and the number of community health workers. But that's I have a fascination for the figure of community health workers and the change agents that they can be as catalysts in the communities they serve, because they belong to those communities. So they are people that are trained, that have a license, and that they know where the big problems are, so they can do that education. They can relate better. They can knock into neighbors' doors and have a coffee or anything when they get back from work and talk about these things. So I believe in catalysts, human catalysts. Yes, I'm a technologist myself, but also I think that human bodies, we've learned with the pandemic that it's great to have Zoom, but it's also great to be in contact, and there's something to be said from getting this real person-to-person contact. So one is community health workers, and the other one that can accelerate trust and diminish fear, and the other one is nurses. I think that nurses are going to be a great catalyst in all these transformations, and I hope so.
Yeah.
One thing I would add to that is representation in those individuals, making sure that we have more Black and brown representation at all levels of clinical work. So inspiring our kids from our communities to go into these things and to increase the pipeline of Black and brown doctors that are in the communities, because there's still a dearth of it. It's a huge problem. And you talk about things like forced sterilization in Black, brown, indigenous communities. There is real reason why people are afraid of doctors, of clinicians.
Oh, yeah.
And if you had more people that came from our communities taking care of our communities, those things would not happen. I would challenge all you guys, watch For Rosa, Power Rosa on HBO Max. Great short film on forced sterilization. Obviously not on the topic, but the great way that they made the film. Coded Bias, if you haven't checked it out on Netflix, great. Also, Joy Bolawini from MIT, great work that she did. All these things are really important. If we just have more representation in STEM from our Black and brown communities, a lot of these things would not occur.
Yeah, I'm glad you brought that into this. I think we're saying the same thing, like trust, fear, and what you just said. Like working in government, my job is to make visible institutional racism, and to make visible. That's just making it visible. And then the question is, what do you do about it? So I love your comment around representation. And then it's also saying to keep building that trust, you have to be clear about the systemic part of the conversation. When you're dealing with the pandemic where there's not clinics or you don't have translation and you're telling folks to put something foreign into their body, like that becomes a thing, right? And so I think all these things played out in the pandemic where we saw all these layers unfold, which made it a challenge. The fear is there based on what you just stated, and so it's government, we have to do differently. We have to make visible the fact that we played out institutional racism in this pandemic. that was a chasm for this country. And so I appreciate all the framing with that, because it's spot on, and we saw it was hard to address it.
A small comment to your point of institutional racism during the pandemic, with the MIT group that has organized. Well, I'm a big fan also of open innovation, open data, and obviously open standards. So we put together a big online endeavor. We were in I was part of the organizing group. We were about 50 people organizing this event for thousands of people that joined. And it was the name. It was a big hackathon, global hackathon, called MIT Hacking Racism in Healthcare. So it was so interesting. We came up with so many different problems, identification of problems in a very global way, but mostly centered in the U.S. But the participation was global, centered in the U.S. because of the, of the topic itself. But it had participation from so many different countries around the world. And it was very interesting to see how so many different aspects popped up as problems. And perhaps many people had not realized that that specific thing was a problem, even working within or participating in some or in any capacity within the hackathon. And so that was one, and the other one was the amount of solutions that were proposed to combat them. So it was very, very interesting, and I'm willing to share that with anybody who's interested also.
I love it. Let's talk a little bit about how government and health kind of intertwine. The CDC describes social determinants of health as key drivers for health inequities, within communities of color, which ultimately places those communities at greater risk for poor health outcomes. When we're thinking about cities such as Jackson, Mississippi, Flint, Michigan, which have high concentrations of Black residents, and the lack of system infrastructure for natural human essentials such as water. How can we use data to address those disparities and ensure the needs of those communities are met?
I would like to just talk about what you had mentioned earlier about the disparity. You first have to look at where these disparities are existing across the United States. Everyone, that has worked in health or healthcare knows that the United States has been slipping in terms of, life expectancy every year. In the next 10 years, I read one statistic, the United States maybe will gain 1 year of increased life expectancy, while the rest of the world will be looking at gaining something like 10 years of additional life expectancy. So we're going to continue to stay where we are or drop back. When we look at the United States, and if we were to take a certain, white, just all the white people of the United States, and we were to assign them as a country, they would be ranked 50th in the world in terms of life expectancy, white Americans. If you were looking at Black Americans, they would be ranked 103rd out of the world in terms of life expectancy. If you were to take Native American populations and assign them as a country, they would be ranked 143rd out of life expectancy. That data proves that the disparities exist in our communities, and these systems are perpetuating those disparities. So when we look at communities like Flint and Jackson, those are the ones that have had the limelight put on them. There are hundreds and thousands of others across the United States that are experiencing or about to experience the same level of urgent community crisis. And unfortunately, where communities are positioned when that happens in a Flint or when it happens in Jackson, Mississippi, is it's all resources, all hands on deck, looking for the funding, looking for the partners, trying to get these things solved. In Flint, we saw it took 5 years or more before they got the pipes fixed and the issues that it caused in children's long-term health outcomes because of lead poisoning. How do we use data to get ahead of that? we have the information. It lives out there. Going back to the very first question, how do we take this data, pull it together, profile these communities, align resources, align goals, bring in our corporate partners that have all of these ESG goals and metrics that they're measuring for themselves, and let's get really aligned on addressing these issues within community. Let's not wait for the next Flint, Michigan.
Absolutely. Kim, I want you to talk about San Diego and what you guys are doing. And San Diego has become a model city for water infrastructure.
Yes, when you were saying all that, I was fighting to jump out of the chair because I think to the question, health is an ecology in connection to government systems. Like this year, our mayor made a historic investment, $800 million in infrastructure. So we think about the word equity, and so that $800 million investment, right now my team in engineering is working on a policy to guide the methodology for the things you just stated, like the waterways, the dams, all these decision making. So government has a role in the health disparities that we see, and you have to get tangible with the products and the product around saying, what are we talking about here? It's a historic disinvestment in the infrastructure, and your government, your taxpayer dollars, you're paying for that. And so when these things fail, you have to ask a question in terms of what policy commands the investment. And then you say, if you're using an equity lens, what does that really mean in terms of how you decide how $800 million is invested in infrastructure, in which neighborhoods don't have the right infrastructure? All these become a part of the conversation to say, this is how you embed equity into policies and practices and budgets. They're all connected, and working with other sectors, you then say, what is our role in that? Well, government, the policy, we have the investment, and we got to make different decisions and then work with health to make sure we're doing the thing. So definitely San Diego, that's why I do this work, is to say we got to make sure that we're clear about what policy commands the money to address the disparities.
And I would only add to that, when you look at these issues and you begin to solve them, there is a huge ROI impact to be had in these cities. When we're talking about the value to cities and private partners getting on board with addressing these issues, we're talking about millions of dollars in reduced healthcare costs. We're talking about millions of dollars in economic development. We're talking about millions of opportunities of people moving to your city, making it a place to live, businesses coming in and investing to establish operations within your city. So this is not just something that we can get on and say, this is a social justice, an economic justice, an environmental justice issue. This is a real opportunity, not only for the individuals, but for every single government leader out there, every single economic development leader out there, every chamber of commerce, every single private business, nonprofits, et cetera, to get behind this, to get aligned, because they will realize the impact in their communities.
I love it. Well, we have a little over a minute and a half. We have one question or no? Oh, yes. Well, I would like to thank everyone for coming in and listening to our discussion. I hope you were able to take away a few nuggets. If you would like to meet with the panelists after the discussion is over, they'll be over here. And also, can we have someone take a picture of us?
I have a phone.
Thank you.